over at the I believe it's the Sarasota, or it could be the St. Pete. I'm so sorry. There is a dosage calc exam occurring at this moment. So feel free to let your friends know. They can pop in at any time. So without further ado, let's go ahead and begin. So what's new this semester? I talked about a little bit of my availability and preceptorship in the past. I do have office hours at the Tampa campus every Wednesday, but I have kind of as needed availability for anyone that might need some one-on-one sessions. Please send me an email. I don't always get Canvas notifications from Canvas email, so the quickest way to reach me is via email. And we can kind of set up some one-on-one review sessions. I also spoke with a few members of your cohort, and you requested some like a pharmacology review session, and I'm in the works of getting the other campus a pharmacology tutor as we speak, that way to best help you guys. But again, that's why it's very important you guys kind of sign up, NAC, all of that stuff, so I can say, hey, here's the need for what resources we might possibly need. So you'll see throughout the PowerPoint, I have nursing in a nutshell. That is a great way to kind of focus your studying efforts and to go ahead and focus your note taking. It really helps us kind of wrap up a really difficult disease process and help us tackle the questions a little bit better. I also incorporated NGN case studies into this PowerPoint. And I know it says live review with Kahoot due to other circumstances. We won't be having that tonight, but I'll be sending you guys a link to the Kahoot, and I will be providing the rationales for you guys as well. So you will have everything you could possibly need. So the first topic we're going to start with today is going to be our respiratory disorders. So the first thing we're going to start with is tuberculosis. So a couple things I want us to keep in mind is that with tuberculosis, there are really two types that we are concerned with. We're concerned with active TB as well as latent TB, and we'll talk about the key differences. Additionally, we're going to talk about some medication considerations and how us as nurses, we can go ahead and keep safe. So I really want you guys to understand that when we have active TB, this is our active infection. Where can we find the PowerPoint? I can't find it. I did send an email a few days ago, so you might have to search back for it. It's also in this chat. The PowerPoint's in this chat, so you'll probably have to scroll up a little bit, but it should be in the chat. So when we're talking about tuberculosis, again, active, think your active infection. You are actively capable of spreading the disease and you're actively symptomatic. So what are those symptoms? Persistent, productive cough, hemoptysis, that's kind of like a blood in the sputum, and low-grade fever and night sweats. Those are very, very hallmark, if you will, of tuberculosis. And what's our gold standard for diagnosing active versus latent? It's going to be our chest x-ray. That's going to help us, and I'll tell you why. With our latent TB, this is when someone had active TB or they have tuberculosis, but it's dormant at the moment. It can become active again when the individual's immune system weakens, so just keep that in mind. If you had a patient with a history of TB and now they're on immunosuppressants for maybe arthritis, their TB might become active again because of their decreased immunity. When we see latent TB on an x-ray, you'll see some calcified granulomas. The best way I can describe that to you is going to be as if someone put a quarter on a chest x-ray and you see like a little quarter showing up on the lungs. That's kind of how we can see latent tuberculosis. So again, it is an airborne disease that will require airborne precautions. So that's going to be your negative pressure room, your N95 respirator, your full PPE, the mask, like eyewear, protective eyewear, things like that. So just really go ahead and review your airborne precautions. Again, airborne precautions are also only necessary for a patient who does have active TB. Again, we went over some of the signs and symptoms. Really pay attention to the last few, the low-grade fever, night sweats, and chills. Those are very, very common and almost pretty much diagnostic of TB. What can we do? We can get an NAAT test. We can also do your tuberculin PPD test. That's the test that they make us get for nursing school, where they do an injection in your forearm and they kind of compare what the diameter does look like. Again, though, our chest x-ray is going to be gold standard. Additionally, we will be putting these patients on an array of medications to treat tuberculosis. The reason we put them on all of these drugs is to really help prevent drug-resistant strains of tuberculosis. Okay, so the most important thing as nurses when we're doing our education is to teach them you need to take all of your meds for the whole time. Okay, this is to help get those 3 negative sputum cultures that they do need. So how can we remember what drugs? We use the RIPE method, our rifampin, isoniazid, pyrazimide, and ethambutol. So I would just review a couple of the main kind of considerations between these medications. I'll name a few. For example, rifampin can turn our body secretions orange. So that's something we want to let our patient know. That way they're not showing up to the ER panicking that they're sweating orange. That's normal for rifampin. For our isoniazid, that drug is really, really toxic to the liver. So again, monitoring our liver function test is really, really important. Our pyrazimide, that one can really worsen gout because it increases uric acid. But really with all of these drugs, we want to stress proper hydration, avoid alcohol. Why? All of these drugs are really harsh on the liver. If we add alcohol to the mix, we don't want to put them into acute liver failure. And then finally for ethambutol, this can put the patient at risk for optic neuritis. So we really want to encourage frequent eye exams for these patients. Again, just really review a couple of your nursing interventions, such as the isolation room, etc. A couple things I do want to touch base on is these patients, if they've been living with their family, the family does not need to isolate. The family does not need to wear a mask around them. Really, if you're living with someone who has tuberculosis, chances are you've probably been exposed to it already and you've probably already got it, whether you might be symptomatic or not. So just kind of keep that in mind. The family really does not need to isolate if they've all been living in the same house with someone with TB. So just keep that in mind. Now we're going to talk about COPD. I really want to focus on what's our patient's normal. What are some of the chronic symptoms and how will we manage this disease process? So COPD is a combination of chronic bronchitis and emphysema. Really our number one risk factor is going to be smoking. And later in this lesson, when we talk about smoking cessation, that's going to be how we help aid our patients in quitting smoking. So really, the issue with COPD is that they have chronic inflammation of the bronchial tree, which kind of impedes that airway flow. Then they have emphysema. Their lungs are hyperinflated, meaning they've lost some elastic recoil. So usually our lungs kind of increase, they expand, and then they constrict. And that helps us give out full breaths, take full breaths in, and get it all out. Well, with hyperinflation, think of something that's just very, very worn down. It's not kind of squeezing as effectively anymore. So these patients just have so many respiratory issues. Our main complications is that we have hypoxemia, which is a decrease in blood oxygen levels, as well as hypercapnia, a buildup of carbon dioxide. When we combine the two together, think respiratory acidosis. If I'm holding on to a lot of CO2, CO2 is an acid. It will put my patient in an acidotic state. We know it's respiratory acidosis because what's the problem? The problem is with my respiratory system. Our bodies are pretty amazing, though. They will try to compensate. So if my body's been starved of oxygen for a while, it's going to look for all of these super cool ways to increase our O2 levels. So how do we do this? Well, our body actually generates more and larger red blood cells. Why? Our red blood cells have hemoglobin on them, and that's going to be really important for transporting oxygen. So that's why these patients have an increased H&H and increased red blood cells, because essentially my body is preparing for whenever we might get extra oxygen, it's preparing to grab that oxygen and use it. So that we might see in some labs. Again, we went over some of the risk factors. A lot of our signs and symptoms going to be more your digital clubbing, barrel chest, hyperinflation of the lungs. These patients are at big risk for cor pulmonale. And the reason that they're at risk for this is because where does the right side of the heart go? It goes to the lungs. Okay, there's an issue with the lungs. It's going to cause the right side of my heart to work extra, extra hard. This eventually contributes to right-sided heart failure. So let's look at some labs on these patients. It's going to be pretty normal for them to have respiratory acidosis, increased H&H. They will sat at around 88 to 92, and that's really important to know. This is the patient's baseline. 88 to 92 is their normal. So if I'm trying to prioritize care and I'm in the ED and I have two patients, I have a healthy 25-year-old athlete who is satting at 88. And I have a patient with COPD satting at 88. Who do I prioritize first? Obviously, I'm going to prioritize the healthy athlete because that is less than my healthy athlete's baseline, okay? An O2 sat of 88 is actually a normal finding in COPD patients, okay? It's not ideal, it wreaks havoc on the body, but essentially it's just a chronic complication from chronic conditions, and that's what this really is. So when we talk about treatment, a lot of them are going to be our respiratory drugs, our beta-adrenergic agonists. That's your albuterol and your salmeterol. Those are your rescue inhalers. They're going to help dilate the airway. They're bronchodilators. Just remember with our albuterol, that's our short-acting beta-agonist, so it works right away. Additionally, tiotropium is another drug of choice for these patients, as well as beclomethasone to really help relax the airway. We want to decrease constriction because, again, that's what bronchitis is. It's that constriction, inflammation. So we want to do our best to really relax everything in the respiratory system. Corticosteroids, again, what do steroids do? They decrease inflammation. Mucolytics can help with secretions because, again, these patients won't be able to effectively cough because, again, all that hyperinflation. As nurses, we should be getting a CBC and a sputum culture because, again, they're at risk for respiratory infection. We really want to maintain their oxygen sats of 88 to 92 and monitor their level of consciousness frequently. If I put a non-rebreather on my COPD patient because maybe he was satting at 80, and then I leave, I get caught up in about 15 other things, I come back and he's satting at 100%. I need to assess his level of consciousness because I guarantee you he's going to be on another planet, okay? He's going to feel higher than a kite because he's got all this oxygen that he's just not used to having. So we really want to make sure that with interventions, we still get that nice 88 to 92 sweet spot for these patients. Again, nutrition is really important because they just burn so many calories simply just trying to breathe. They burn about 3,500 calories a day. That's their resting metabolic rate, just because, again, their work of breathing is so increased. So what can these patients do to kind of help when they're having issues with breathing? Pursed lip breathing is very effective. That's where you kind of in through the nose, you inhale the roses, and then you blow out the candles. Also, diaphragmatic breathing helps. And above all, smoking cessation. Now we're going to talk about our obstructive sleep apnea. So I want you guys to pay attention to our arterial blood gases, some risk factors. We're going to talk about treatment do's and don'ts. Especially with OSA, the don'ts are very, very important. And then we're also going to review narcolepsy. So, what is happening with obstructive sleep apnea? Essentially, during sleep, when the patient is sleeping, their soft palate falls into their throat and it cuts off their airway. Well, what happens when my airway gets cut off? My oxygen levels drop, and if I'm not getting rid of my carbon dioxide, I'm going to become acidotic. So again, like COPD, we have the hypoxemia and hypercapnia. Puts my body in a acidotic state. What happens when I'm in that acidotic state? My body actually wakes itself up because it senses an issue with my homeostasis. Really, there's many risks and complications associated with this, specifically our narcolepsy. That's a really, really big concern. Risk factors: obesity, short necks, smoking, etc. So when we talk about our diagnostics, getting an overnight sleep study is going to be the best for these patients. But typically, the patient's significant other, roommate, partner, etc., is going to kind of report that they've been snoring. These patients wake up about 5 to 10 times an hour, so they're not getting a full night's rest. And that's really just a big issue because there's many negative health associations with lack of sleep. So, what can we do for treatment? I want you guys to understand our modafinil. This is for daytime. This promotes daytime wakefulness. It helps with the narcolepsy, but this is not going to treat the issue. It's simply symptom management. What are we going to do to treat this? Well, we're just going to have to provide oxygen at bedtime. There's loads of different masks you guys can use for these patients. However, our CPAP is our best. This is our constant pressure. It's going to give constant airflow and pressure in through the nose, in through the mouth, down through the throat. That way it keeps that airway open. Okay. Keeping in mind, if we are treating these patients, we want to avoid sedation medications. Essentially, the only thing, because these patients, they stop breathing at night. That's essentially what happens. The only reason that these patients, for lack of a better word, are alive is because their body wakes up. My body wakes up so that they can take a breath in. But if I give them sedation medications, they're not going to be able to wake themselves up, and that is not good. We also want to avoid alcohol or other CNS depressants because, again, we want to make sure that they are waking themselves up. We also don't want to give food before bed because of risk for aspiration. Now we're going to talk about our allergies. We're just going to review some of the medical emergencies and some other fun considerations. I wouldn't recommend spending too much time going over allergies, but I just want you guys to kind of have a general understanding of what's happening and that allergens can really be inhaled, ingested, injected, absorbed, or contacted. Loads of different symptoms kind of ranging from moderate to severe. So it's always really important to assess your patient. So what are some of our severe allergies? Okay, this is going to differentiate our seasonal allergies from our medical emergencies. So we have anaphylaxis. This can lead to hypotension, a drop in blood pressure, angioedema, angioedema, facial swelling, or severe hives. Okay, that's an emergency. We need to administer some epinephrine. In the meantime, we can give some supportive symptom management methods of treatment, such as antihistamines, mast cell stabilizers, possible allergy shots. Some complementary and alternative measures can include vitamin C and zinc. I really want you to stress the caution of decongestant nasal sprays because if a patient's been using them prolonged for a long time, they can have a rebound runny nose. So meaning they stop taking their nasal spray and all of a sudden their nose will not stop running. Okay. However, when we're talking about treating allergies, the best way to treat an allergy is to identify the allergen and avoid it. Maybe our patient doesn't know what's causing his or her allergies. Make sure that they do a journal maybe to help kind of figure out, because that's going to be the best way to avoid all these negative symptoms of allergies, is to just avoid. And that's going to also be the most effective. Okay? The most effective way to treat allergies is to avoid them altogether. Now we're going to talk about asthma. I really want to stress the importance of prioritization, specifically of the medications, and really focus your review on proper inhaler care. How do we use it? When do we use it? How do we educate our patient to use their inhaler? That's going to be very, very important with asthma, so I encourage you to review those as well. Okay. So when we talk about our asthma, again, it is a inflammatory disorder because of a hyper-responsiveness to a trigger. Okay, what's happening? Many different pieces can come into play. But really, main concept is there's a narrowed lumen interfering with airflow and gas exchange. Lots of different risk factors, etc. We also diagnose asthma with some pulmonary function tests. Signs and symptoms, I really want to go over wheezing. Wheezing is very common with asthma. But if I'm working in the ED and a patient's coming in with an asthma attack and I assess them, we always assess first, we get some vitals, and I auscultate and I hear wheezing. And I go to grab some other things, some medications, maybe they needed water. I go and I grab that and I come back, I auscultate again, and they're no longer wheezing. That does not mean they got better. It means they got worse, and I'm having an emergency right now, because that means that the airway has completely closed. That's why I'm not hearing a wheeze anymore. Okay. You might also see increased work of breathing, use of accessory muscles, etc. Just to go back into the PEFR, I want you guys to review those. I believe in a pre-class worksheet, there was a chart with PEFRs. Just review that because this helps us determine how severe this is, and severity helps us determine what meds we need to use. So if someone is in the red zone, it means that they need their emergency rescue inhaler. This means that their PEFR is 50% of normal. And that's really, really bad for these patients. They are breathing half as well as they normally do. Yellow zone, again, probably going to want to get our rescue inhaler. Still have a little bit of time. And then green is good. Also, we want to review after we've given the medications. If we have given our medications, we want to really assess. And I'm sorry, it seems that my PowerPoint has somehow disappeared. Can you guys still see my PowerPoint?
Yes.
Okay. Okay. All right. Sorry, I don't know where my PowerPoint went on my screen, but I will try to pull it back up. If not, I do have my phone going, so it can help me.
Are you able to let Lauren into the chat? Her notification keeps popping up like 50 times on my screen.
I can try. I keep admitting her, and it says that she gets admitted, but
yeah, it's just like popping up constantly.
I know. Let me see. I can let's see if that works for her. I think it might be an issue with her computer, maybe, because I keep admitting her like every time she pops up. Can anyone else maybe admit Lauren?
I feel you. I tried.
Okay.
Didn't work. All the same issue.
Okay. All right. Okay. Well, I did get my PowerPoint back up, so that's good. Okay. So again, PEFR, if my patient was in the red zone and I gave them their rescue inhaler, after a few minutes, I want to have them do their PEFR again. If we're moving in a positive trend, a positive direction upward, that's good. It means my treatment is working. Okay. So what are some treatments? For inflammation, we can give beclomethasone and prednisone. However, this is for inflammation. These patients usually take these drugs on the daily. It's not for an emergency. If my patient is having an emergency, I need to give them albuterol, which is a short-acting beta agonist. It means it works for a short amount of time, but the onset is very, very, very quick. So this is what's going to help open up their airway in an emergency. Additionally, your salmeterol, your Spiriva, all those other ones are great for preventing attacks. But what do we give these patients when they're having an attack? We give them their SABA, okay? Let's say you have a provider order for a patient in their red zone and they need their albuterol, and let's say they need prednisone. Well, we give them their albuterol first to open up the airway, and then we can give them their prednisone, because it's going to do no use giving them prednisone if their airway is completely closed. It's not going to get where it needs to go. Okay, so nursing interventions, we use the airway breathing circulation approach. We establish an airway, we give oxygen, specifically when we're doing meds, rescue inhaler first, and frequent respiratory assessments. We also should teach these patients how to use their inhaler and to always carry their rescue inhaler. Someone has asthma and they're only walking around with Spiriva, it's probably not going to help them in an emergency. Okay. So I do have a next generation NCLEX style practice question for you guys. This is what's going to be on the next gen NCLEX. In terms of exams, you might have a few NGN questions and then some traditional NCLEX questions. But as the course and as your program progresses, you'll start to have more and more questions. Will Mr. Frolov add questions like these? I can't speak for Dr. Frolov, but because I've primarily worked with another professor, but Mr. Frolov was co-teaching. And again, there is some NGN case style questions. Again, for your first exam, it builds, if that makes sense. So you might have 1 or 2 your first exam, and then your second exam, you might have 3 or 4, and then it builds that way. That's what we've done for Complex Health 1 in the past. But that might be more of an appropriate question directly to Mr. Frolov. But I can tell you what we've done in the past together. Okay. So just to get you guys familiar with these questions, we have your assessment and case scenario kind of on the left, and then on the right we have a indicated, contraindicated, or non-essential. So when you're tackling these questions, we have to kind of know really what's happening. So if something is indicated, it means, yes, please do this. This is pertinent to the disease that is being discussed or the issue that is being addressed in the practice question, in the case scenario. If something is contraindicated, I want you to think false. That is not true. Just not true. Okay? When something is non-essential, it means it could be right, it could be wrong, but it's not pertinent to this information. For example, if I am working with a patient who is having a breathing emergency, now might not be the time to work with physical therapy, okay? It might not be the best time. Maybe they can come back. So it's not necessarily that it's wrong or right, it's just not pertinent to what the question is talking about. So I encourage you, when you look at this practice question, we'll read it out, we'll do it together. What's this question asking me about? So as we look kind of through this, we have a 50-year-old male who comes to the ED for what appears is a broken bone, a fracture of his leg. Okay, he's waiting to go to the OR, but upon further assessment, we noticed he's in really bad pain. He has a low-grade fever, and the client reports he has fatigue, lethargy, night sweats, and a bloody cough for 4 months. So what do you think is happening here in this question? Do you guys kind of have any ideas of what this question might be asking us about? What's happening, maybe? You can unmute yourself, you can pop it in the chat, whatever you're more comfortable with. Yes, this question is kind of giving us possible tuberculosis. Could be internal bleeding as well. But when we kind of look at it, they have really bad pain, which is normal for a fracture. But it says that they've been having fatigue, lethargy, night sweats, and a bloody cough for the past 4 months. So I'm not thinking it's a normal cold or flu because it's not going to last 4 months. But they're showing these symptoms. And when you see these symptoms, these are pretty hallmark of a specific disease process. And what disease process did we learn about today? Tuberculosis. Remember we talked about that bloody cough? That's hemoptysis. Hemoptysis is that bloody sputum in the cough. Lethargy, night sweats. I want, whenever you see that night sweats and that frothy sputum, I want kind of light bulbs to go off. Okay, possible tuberculosis, possible tuberculosis. So what are we going to do for these patients? Do we think that it is indicated, contraindicated, or non-essential? Should we notify the surgeon and OR immediately? What do you guys think about that? You can just put an I, you can put a C, or you can put an N for indicated, contraindicated, non-essential. Good job. Yeah, it's going to be indicated. Why is it going to be indicated? Well, this patient's about to go to the OR. I need to tell the OR staff, hey, this patient has possible TB and we need to confirm this diagnosis and we need to protect ourselves. We can always put them on an isolation precaution just to be safe. And let's say we get a test back and it's negative. Well, it doesn't hurt to be safe. Rather be safe than sorry. What do we think about the next one? Administer prescribed pain medication. Do you think it's indicated, contraindicated, or non-essential? Awesome job, guys. Yeah, it's going to be indicated. I had a couple questions last time. Why is it indicated versus non-essential? Well, let's look at what the case study gave us. The case study told me his pain is 8 out of 10. That means it's indicated for the situation because the question specifically addressed my patient's pain level. So, yes, it is going to be indicated for this patient. What do we think about making the client leave the room? What do we think about that one? Okay, this is where it can get a little bit tricky. So when Next Gen NCLEX is asking you about non-essential, that doesn't mean not necessary to the situation. It means, that probably wasn't the best way to describe it. But for example, the correct answer would be contraindicated. That is false. If the family does not need to leave the room because if they've been living with this patient, they've probably already been exposed. When you see non-essential, it doesn't mean, oh, it's not essential for the patient's family to leave. It simply means not pertinent to whatever's happening. And I know that can be a little bit tricky. That's why practice questions are the best way. But whenever you see contraindicated, literally think false. Read the question, making the family leave the room. Well, that's false. They do not have to. They specifically don't. It specifically says they don't have to leave the room. So that's how you could kind of work through and tackle these questions. But again, practice and repetition are really important. What about collaborating with the registered dietitian nutritionist to determine the client's nutrition state and needs? So this one is actually non-essential. The question didn't really provide any sort of information about my client's nutrition status. And at the moment, it's non-essential, meaning at no point in this little case study did it ever address anything involving nutrition. So yeah, most of our patients do meet with a registered dietitian, but it's non-essential for this situation. Because see how it was never really addressed and it's not pertinent to tuberculosis at all? Yeah. What about asking the family to wear masks while in the client's room? This one was a little bit tricky, I will say. Um, Yeah. So this one, according to ATI, it lists it as like non-essential. I'm not, I'm sorry, I can't really give you the best reason why. I was reviewing the rationale and it didn't really give me a good rationale. But ATI said that that one was non-essential. If I can give you guys a better answer, I will. I'll have to look into it further, but don't worry too much about that one. And the good thing about NG and NCLEX is the next gen questions are not all or nothing. Does not say if family lives with him. Oh, I skipped one. Oh, I'm sorry. Okay. Yeah. Okay, I'll go back to the one I skipped. Don't worry. But yeah, it didn't say if they. It says making the family leave the client's room. That can be a little bit different. But it says like in the question, his family was his wife and 4 children. So I'm assuming that they already live with him. But we'll go back. What about placing a mask on the client? Is it indicated? Is it contraindicated? Is it non-essential? Yep, it's going to be indicated. If we go back to our airborne precautions, when we are not in a negative pressure room, and the patient is not in a room by themselves, the patient needs to be wearing a mask, especially for transport. Should we perform the tuberculin skin test on this patient? Mm-hmm. Yep. A tuberculin skin test is indicated for this patient specifically because they are showing symptoms. We always want to get a skin test. These patients will actually get multiple tests. They will get a chest x-ray. They will get a skin test. They'll get a lot of different tests done. What about performing the skin testing on the family members? What do we think about that? Yeah, so this one again, a little bit tricky, but this one actually is non-essential. The reason that this is non-essential is right now we do not need to be doing this if these patients were to follow up with symptoms, but at this moment is, if he is, the family is. Well, we don't know much about the family. We're suspecting tuberculosis for this patient because he's reporting fever, lethargy, bloody cough. He's reporting like an active infection. And right now, a TB skin test is non-essential for patients not showing symptoms, if that makes sense. It would definitely require further follow-up. And I know these questions can be a little bit tricky, but I did get them directly from not only your textbook, but ATI as well, just because I wanted to expose you guys to these questions the best that I could. So these are difficult questions for sure, but you guys are doing very good. Should we report the possible tuberculosis infection to the local health department? What do we think about that? There's one key word in this sentence that kind of helps you figure out the answer. Awesome. It's non-essential. Do we report a possible infection? No. We report a confirmed infection. Absolutely. So this is a non-essential at this moment. And also when we're thinking of like contraindicated, I want you to think of like what could possibly harm the patient. When I was reviewing these like ATI rationales, why it's contraindicated to ask the family to leave the client's room, it's because it could put the client at like an anxious state. Making their family leave, having them all alone could actually give them lots of anxiety. So contraindicated also kind of goes along the lines with like safety and best patient outcome. That can also help you when trying to figure out the difference between contraindicated and non-essential. So non-essential is like not pertinent right now. You could or you couldn't. And contraindicated is kind of like false. It can also like harm or do harm to the patient, if that also makes sense. So kind of when you think contraindicated, it's going to result in a negative outcome. So again, this is from ATI, all the correct answers. Now we have another question. 6-year-old male client with long-term COPD has been losing weight at a rate of 45 pounds per month for the past 3 months. He and his wife are both distressed by this weight loss, especially because the client's other symptoms have remained stable. They both consider this weight to be a negative health sign. Select to indicate the actions that are most appropriate for the nurse to help this client with the weight loss problem. So, and this is what Next Gen likes to do, what do you guys think is an appropriate NANDA diagnosis for this? What do you guys might think? It's asking like priority problem. That's what this question's asking us about. I can think of imbalanced nutrition, less than the body's needs. This question specifically asking us about like COPD and the patient's weight loss. So, what do we think would be some good choices for helping this client with the weight loss issue? Should we ask them about any factories or heavy industries within the residence? Do you think that could contribute to this weight loss problem we're having? Yes, no? Correct. That's not really contributing to the weight loss issue. Now, maybe if he was having like issues with breathing, we would ask that question, but he told us that he doesn't have any other symptoms. What about the second one? Similar concept. Do we think it's appropriate, inappropriate? So really, yep, nope, not really important for the weight loss. What about this one? I know you guys haven't learned too much about nutrition yet, but what do we think about how often do you prepare food by barbecuing or grilling? Do you think that's important to ask? So this one actually is an important thing to ask because it's talking about nutrition. We all know that no, not that much inhaling smoke. When we're talking about food by barbecuing or grilling, this question kind of helps us assess what our patient is eating. I know we don't want like fried fatty foods. It's better than other ways of cooking. That's great. But remember, this patient is having a weight loss like issue. He's been losing weight and whatnot pretty quickly, I'd say. But that's okay. So yeah, we want to ask more questions about the food that he's eating. How is your residence heated in cold weather? I don't typically like that question because I think it's a little bit advanced, but it really kind of goes into if you're kind of cold and just the kind of weight stuff associated with it. So we'll skip that one. I think it's a bad question. Do any members of your family have an alpha deficiency? Again, not really important to weight loss. Or weight loss, weight gain. It's not weight related. Okay. How old is your residence? That also kind of goes along the lines of like the house. And kind of like the heating in the house. Again, I don't like that question either. What kind of work have you done in the past? That's important to note because we need to kind of compare, does my patient have a very active job? Is maybe that kind of contributing? Racial and ethnic heritage also play a really, really big role in weight. So that's also something you kind of want to ask these patients. And then the rest are really not pertinent. So again, this was on ATI, it rates. Is this a difficult question? Is it moderate? Is it easy? This was a difficult question, but you guys did really, really well with answering these. But these are just like your next gen. Okay. This is also another style of question you guys will be getting for NGN. So this one is assessment findings and was my treatment effective, ineffective, or completely unrelated. Okay. So essentially we have a patient coming into the ED with an asthma attack. After assessment, we note that they have audible wheezes on inhalation and exhalation, and our pulmonary function tests are below her best. They're 50% below normal, or her best. We have a list of her vital signs, some asthma management, etc. So after providing some nursing interventions, we do a follow-up assessment. So based on our assessment findings, do we think our treatment was effective, ineffective, or unrelated? So my patient has audible wheezing present on exhalation only. Do you think that was E for effective, I for ineffective, or U for unrelated? Awesome. It's effective. Why is it effective? Well, we look at trends. Trends are a really big concept in nursing. When she came in, she had wheezing on inhalation and exhalation. Now she only wheezes on exhalation. So that's pretty good. What about a temperature of 98.6? What do we think about that? Awesome. Good job, guys. It's unrelated. It is completely unrelated. Asthma has nothing to do with body temperature. Okay, what about her PEV1 is 70% of normal? Awesome, it's effective. They were 60% of normal. Now she's 70% of normal. Again, we're trending in an upwards direction, and that's what it's all about. My client states that she's frightened. Look back to the part where it says on further assessment. Further assessment, the nurse finds the client to have suprasternal and intercostal retraction. She can speak 4 or 5 words between breaths and states she's frightened. Great job. Ineffective. My patient came in, said they were scared. Treated them, they still say they're scared. It means I'm not kind of meeting their psych needs. Maybe I need to be a bit more reassuring. Maybe they still don't feel good. So something was ineffective. My patient still feels the same way they did when they came in. All right. Blood pressure 152 over 100. What do we think about that? So, I see a lot of ineffectives. I get where you're coming from because when they came in, the blood pressure was 144 over 96. Now it's 152. But does asthma have anything to do with blood pressure? An increase in blood pressure? Is that really? Yeah, not really. Increased work of breathing can increase blood pressure. That's actually not always going to be the case. Um, and because the anxiety can also increase their blood pressure. But again, we kind of have to be looking at trends And I know it's like frustrating. Great. I like the way you guys are thinking. I really do. I think that's awesome. But realistically, if my systolic went up by 8 points, they're still kind of in a normal blood pressure range for the situation. So at this moment, it actually is unrelated. Um, yes, the anxiety could be contributing to that, but do we know for a fact? We really don't. And NCLEX is very kind of like black and white. So the blood pressure is actually unrelated. Again, looking at like trends, and this will make a lot more sense when we talk about cardiac, but if my SBP changes by 8 points, it's not it's not as scary as you might think. It's actually pretty normal. What do we think about our O2 sats of 86? Yep, it's effective. She was at 80, now she's at 86. Again, really good trend. What do we think about the pulse being 130? Kind of think back to what I said about blood pressure. Can and this is kind of what I want you guys to kind of think about it. Can we definitively confirm that this asthma issue is contributing to this heart rate, this blood pressure? Well, if we go back to patho of asthma, we can't. And the next gen likes to tie in a lot of patho. When we're talking about pathophysiology, does asthma attack have anything to do with blood pressure? No. Anaphylactic shock, maybe. Now we're talking. But asthma, no. Okay. All right. What about no retractions visible? And my patient has no retractions. Good job. It means that treatment was effective, and because they came in with retractions and now they have none. So again, I provided you guys like the answers. Here's the answers. Just so you know. Also, I just wanted to kind of touch base. I know it's pretty easy to get discouraged. These are very difficult questions, but I choose these questions because they are difficult and I can kind of help add more to them. Also, I just think that there's so much to learn from these questions, and I want you guys to get comfortable with these questions so that when we all sit down and we take our boards, that we're going to have success with those. And the only way to do that is by exposure to these types of questions, okay? And I think personally, you learn a lot more from getting things wrong than you do from getting things right. So don't take anything to heart. You guys are really, really doing good. Now we're going to bounce into some neurological disorders. So when we're talking about Parkinson's, I want us to identify the imbalance of the neurotransmitters. This is what dictates treatment. Hallmark signs and symptoms, some nursing considerations, and what are we really prioritizing with Parkinson's disease? So, Parkinson's, what's happening? We really don't know what the cause of Parkinson's disease is. All we know is that there is a drop in dopamine and an increase in acetylcholine. So, these neurotransmitters, they like to balance each other out. If I have a drop in one, I'm going to have a rise in the other. It's not super important to know like what's happening with dopamine and acetylcholine. I gave you guys kind of a bit more information on that, but essentially my neurotransmitters are imbalanced and they're out of whack. What do neurotransmitters do? They help us make mind to muscle connection, and not just mind to muscle like I want to go pick up my sweater. No, my mind to muscle also includes my mind telling my lungs to contract or to expand. Okay? So the goal of treatment, knowing what the issue is, the goal of treatment is to increase dopamine and decrease acetylcholine. Hallmark signs and symptoms, we have our pin rolling tremors, freezing gait, mask-like face, stooped posture, cogwheel movements, feet shuffling, etc. Those are hallmark of Parkinson's. So, how do we treat this? So, we give them some dopaminergics. Remember, we want to increase dopamine. Our drug of choice is levodopa and carbidopa. The reason why this is our drug of choice is this is a combo drug, okay? It's so much more effective than just giving them like plain levodopa. Because in order to get to the brain, we need to cross the blood-brain barrier. So essentially, when we do this combo drug, I like to describe it, the levodopa gets on the car, and the car transports it across the blood-brain barrier so that after it crosses the blood-brain barrier, the levodopa can work on the brain. So that's why we do a combo drug. It helps it last longer. Helps the drug last longer. It helps the drug pass B. Also, we give them anticholinergics to help drop those levels of acetylcholine. What do you need to know about anticholinergics? They dry you up. Dry tears, dry mucous membranes, urinary retention, dehydration, etc. So those are your nursing considerations of your anticholinergics. Okay? A couple other different meds you guys can review on your own, but I think the first two are the most important. As nurses, we do need to be cautious about the risk for aspiration, specifically aspiration pneumonia. Once they choke on something, they have risk for aspiration pneumonia. So what can we do? We can keep suction at bedside, keep the head of the bed elevated. We can teach them to do chin tuck swallowing. And really give them a safe environment. We know that they have this issue with kind of moving and walking, so have them rock a few times before they get up. And for that freezing gait, have them march. Additionally, if we haven't gotten a swallow study done on these patients recently, we need to give them a swallow study just to determine really if they can swallow. Because if we don't know kind of what their ability is, they could choke. This is also an assessment you guys should be doing when you go to chart on your patients in clinical. If you actually go to the respiratory section of the chart, there's something where you get to rate if your patient is capable of swallowing or not. Have you seen them take a sip of water? Are they capable of doing that? So I encourage you to look at that too. Now we're going to talk about Huntington's disease. So what's happening with Huntington's? Essentially, it's kind of the opposite of Parkinson's. Now they have way too much dopamine that's contributing to this chorea. Specifically, these chorea dance-like involuntary movements. And essentially with Huntington's, once the symptoms present, it's about 10 years till unfortunately they pass away due to mobility and respiratory issues. Essentially, they have a harder time making mind-to-muscle connection, which kind of limits their mobility. It limits kind of their ability to, like, let's say, play piano. That's a good example I like to use because as they start out playing, they might be playing the notes very, very fast. But as the disease progresses, their notes might sound a little bit slower just because they're having a lot harder time, with that mind-to-muscle connection. Can also lead to some progressive dementia and difficulty swallowing. The issue with Huntington's is that if you have it, there's a 50% chance of you giving it to your offspring. So it poses a major ethical question and more of a psychological question to parents that know if they have a Huntington's trait, that they could potentially pass it down to their child. What can we give for treatment? Really, again, treatment is supportive. So we can give them some anti-chorea, such as tetrabenazine, to really help with these chloroform movements. Again, aspiration pneumonia, review your aspiration precautions, meaning have suction at bedside, get respiratory therapy involved, speech therapists come and do a swallow study, all of that stuff. Now we're going to talk about multiple sclerosis. When you think multiple sclerosis, now we're having some sensory issues, okay? Sensory issues across the board. With multiple sclerosis, this is an autoimmune inflammatory response that attacks our myelin sheaths. Myelin sheaths help us effectively send a nerve impulse. So think of it as a nice, new, fresh paved road. I can gas my car 50 miles an hour across a nice, straight, paved road and go fast because there's no potholes that could slow me down or make me run off the road. Now, if that road were to have maybe 15 potholes in it, and I gas my car 50 miles an hour, I guarantee you my car's not going to go 50 miles an hour. That's a similar concept with multiple sclerosis. We're just having a delay in our nerve impulse being sent through, okay? Multiple different types. I wouldn't recommend memorizing relapsing, remitting, primary, progressive. Just know that once a patient has an exacerbation and there is damage done to the myelin sheaths, our myelin sheaths won't regrow, renew themselves, etc. Once the damage is done, it's done. Okay. Viral infections can put these patients at risk. Exacerbations, what can exacerbate the disease are times of stress, decreased immunity, etc. Just again, review some of these signs and symptoms, specifically our muscle spasms, our UTOF sign, decreased perception. Urinary retention is a big one because, again, mind to muscle. The bladder is a muscle. So if my brain's having a hard time kind of telling my bladder literally to open, close, relieve, however you want to put it, these patients do have a lot of urinary retention issues. Okay. So yeah. What can we give them? We can give them some immunomodulators. Just a heads up, lots of your immunomodulators, such as your, I could not pronounce it, but like infliximab, lots of your immunomodulators, they end in that MAB. Okay, so that's just like a good rule of thumb. If you see a medication, you might not know what it is, but it ends in that like UMAB. That's kind of like, oh, most of our immunomodulator drugs end in that UMAB. And again, our immunomodulators, they kind of help suppress the immune system. So just keep that in mind. We can give them some more immunosuppressants. We all know corticosteroids suppress the immune system. Muscle relaxers are very good. Dalfampridine is a good one. So yeah, but essentially we just want to prevent exacerbations and help promote functionality. A big thing for nursing, help these patients prevent UTIs, get them on a voiding schedule. They can do the Krebs maneuver to help with urination. Even some like good pelvic exercises are very good for helping to kind of work out the bladder and stuff. It kind of helps strengthen that. So yeah, also really, if my patient has an immunosuppressant, an autoimmune disease, how do we treat that? We suppress the immune system. Well, what do we need to know when we suppress the immune system? My patient's at risk for infection and they can get very, very sick. So infection prevention is key for these patients. So avoiding stress, triggers, sun, infection, crowds, all of that. So I encourage you to kind of review your immunosuppressive precautions. They're also very similar to precautions for patients with cancer and who are on chemotherapy. So ALS, we're going to talk about a priority concern and some interventions. Okay. So ALS, this is our chronic progressive neurodegenerative disorder. It really targets the central nervous system and the brain. Just know that ALS is a terminal disease. You also might hear it called Lou Gehrig's disease, named after a famous baseball player who needed to step down due to this diagnosis. Death is usually within 3 to 5 years due to paralysis of respiratory muscles. I want you guys to think the loss of function starts in the extremities. It slowly creeps inward until it gets to the lungs, where unfortunately your lungs become paralyzed and they can no longer breathe on their own. And that is how these patients pass, if not due to mobility respiratory issues. So again, lots of signs and symptoms. Fortunately, there is no definitive test. We really just rule out everything else. There's no cure. Really, it's a bunch of symptom management and promoting the function that they have left. Riluzole can help slow the progression, but it's not like it'll give you an extra 10 to 15 years, maybe 3 extra years tops. A Darvone can also help, but really we want to be doing a team approach with around the clock care. These patients are on aspiration precautions. Most often they will be receiving nutrition artificially through a G tube through the stomach. And really discussing EOL care and palliative care measures, advanced directives, living will is very, very important. So now we're going to kind of switch and we're going to talk about some migraines. Is there a medication we can use? And what are some patient-centered care things we can kind of incorporate? So lots of different types of migraines. I encourage you to kind of just review a little bit of it. But really know lots of our migraines present with the same symptoms, such as photophobia, nausea, vomiting, and a unilateral like pulsating pain. Like it's on one side, you like can feel it, etc. Lots of different phases. So yeah, just review just very, very basic parts of those. Really, our treatment for this, we can have, there's two types. We want to prevent first, and then if we can't prevent, we can kind of manage a little bit. So really avoiding triggers is going to be really important. You can do some CAM measures. That's just complementary and alternative medicine. And then we can use abortive therapy, such as NSAIDs. This can be used like if a patient has an aura or really before the like start of like more of your symptoms where you kind of just feel it coming on. Or if it's a really long ongoing migraine, you can give them sumatriptan. But as nurses, really migraines are common. Put these patients in a cool, quiet room. Elevating the head of the bed helps. And really, please, please, please just leave these patients alone. Getting a good set of vitals on them the minute they come in is great. But do we want to be in there every 15 minutes, knocking on the door, turning the light on? No, we need to let the migraine run its course, keep them very, very comfortable. Now we're going to talk about SLE. We're really concerned about our main complication. So yeah, essentially what happens with SLE, this is another autoimmune disorder where essentially immune complexes deposit anywhere in the body. They like to deposit in the joints, the kidneys, and the heart. Well, what happens when an immune complex like lodges itself somewhere? It's going to trigger an inflammatory response to that area. So if it lodges in the kidneys or the heart, it can really cause mass inflammation to those organs. Marco, I knew someone who died from lupus at 19 years old. I'm very sorry about that. Unfortunately, with lupus, if not managed effectively, it can have major damage specifically on the organs, because as these complexes deposit in key organs such as our kidneys and our heart, it leads those organs to be ineffective, which can kind of lead to organ failure. If it deposits in the liver, the patients are at risk for liver failure, kidney failure, heart failure. So it really is important to kind of manage, because the complications, obviously inflammation everywhere. So yeah, it really is a very serious disease. Our hallmark signs and symptoms, that's going to be our butterfly rash, our Raynaud's phenomenon, painful swollen joints, really wherever there's an immune complex, and this is a systemic disease, wherever these complexes deposit, you're going to have massive inflammation in the area. So what do we see in these patients? Elevated inflammatory markers, and some lupus cells as well. What can we do for these patients? You can give them NSAIDs for pain and inflammation, but this is contraindicated in kidney impairment. So if you have a patient with SLE and they're having impaired kidney function, and you look at their BUN and their creatinine and those are increased, that's how we can kind of dictate whether the kidneys are involved. If they're not showing any signs and symptoms of kidney impairment, we can give them some NSAIDs. Corticosteroids, again, not only do they suppress the immune system, they also help with inflammation. Immunosuppressants, methotrexate and belimumab, that's kind of the MAB drugs I was talking about, those immunomodulators. So really teach these patients to avoid live vaccines. Hydrochloroquine is a drug of choice for rheumatoid arthritis. Patients with SLE will almost always have rheumatoid arthritis. What's rheumatoid arthritis? That's just the systemic arthritis, okay? It's not your osteoarthritis, which is wear and tear, but we'll talk more about that when we go over those concepts later on in the course. So really assess for some complications such as chronic kidney disease, cardiovascular impairment, frequent skin assessments, and really these patients are on immunosuppressants, so teach them if you have a really high fever, call your doctor, avoid ill individuals, avoid crowds, etc. Okay, so I have a few more practice questions for you guys. Again, effective, ineffective, unrelated. 62-year-old male client has been treated for Parkinson's disease with multiple drug regimens for over 10 years. He's retired and lives at home with his wife of 40 years but no longer drives. Client visits his PCP for an annual exam. The nurse assesses the client prior to his examination. So for each assessment findings, indicate if the interventions were effective. So remember, this is at a PCP, primary care provider. This patient is just coming in for a little checkup, okay, after drug regimen. So if my patient is independent in ADLs but needs help with balance when bathing, do we think that's effective, ineffective, or unrelated? Good job. It's effective. Remember, these patients, our goal is independent ADLs. That's your activities of daily living. So they can brush their own teeth, they can brush their own hair, they can button up their shirt. Needs help with balance when bathing? Not a really big issue. So for the most part, our medications are working. What about walking independently with a walker? Do you think that's effective, ineffective? Awesome, yes, that means treatment was effective. Very good job. What about difficulty sleeping most nights? Correct, that is ineffective. What about they have a rash on both legs that responds well to hydrocortisone? Effective, ineffective, or unrelated? Good, good. It's unrelated. There's no Parkinson's disease doesn't have anything to do with a rash. He probably just has a rash. What about he is sometimes dizzy when getting out of bed in the morning? Good job. Ineffective. Dizziness, that's a safety concern. Risk for falls. This patient's on a lot of medications that are probably contributing to that orthostatic hypotension. So that means that something in our treatment is ineffective. It's putting the patient at risk for harm. Excellent job. What about he has occasional resting tremors that do not interfere with ADLs? What do we think about that? Awesome job. It's effective. Very, very good. It's not interfering with his ADLs, and unfortunately, the resting pin rolling tremors are just normal with Parkinson's. But what's important is that they have these symptoms, but it's being managed well enough that it's not interfering with anything. What about having osteoarthritis in both feet? Good job. It is completely unrelated. What about reporting pain of 3 out of 10 in both feet? Effective, ineffective, unrelated. Awesome job. It's unrelated. And again, here are the answers for your review. This one is about nortriptyline. I know you guys haven't covered this in pharmacology class yet, so I'm going to skip this for the most part. But I just want you to know, nortriptyline is an injection that can be used for patients that have been having an ongoing severe headache. Sorry, let me pull up the chat. Why is not sleeping well? Oh, sorry. Why is not sleeping well considered ineffective for Parkinson's? If you go back, like with more like kind of reviewing like some of the common medications for Parkinson's, a lot of those like side effects, adverse effects are like the patient's kind of irritable and not sleeping. Parkinson's is also kind of in that Alzheimer's category. So kind of that not sleeping. We know these patients need lots of rest, especially because of all these like symptoms they're experiencing. So if they're not resting, that is more of a safety issue. Does that make sense? Because we know that like one of the nursing interventions for Parkinson's is to take their meds in the morning so that they feel nice and awake during the day and kind of can function during the day. Okay. So back to this question, nortriptyline, essentially it's an injection, or sorry, that is the med that they've been taking. It's not working. Now my primary care provider is providing erinumab. Okay. What do we know about the UMAB drugs? Those are some drugs that we can actually like inject for like modulators and stuff. So really, this one is a little bit advanced for you guys, but really it kind of goes down to knowing what that drug is, how we give it. So monitor the injection site for pain, swelling, redness. We're giving this erinumab drug to help with kind of reducing the frequency of migraines because she's having 12 to 20 a month. So you did a really good job though. It's a really good question. When I made this PowerPoint, I was unaware that you guys hadn't learned about these drugs yet in pharmacology, because when I've taught this in the past, everything you learned in pharm was going along the lines of complex health 1. So no big deal. You'll learn about it eventually. So this question is asking us about some chronic conditions that can contribute to the risk of visual problems. So don't worry too much about the last two, but what have we talked about that we know puts a patient at risk for visual problems? What disease process can, of these disease processes, what impacts vision? What 2 diseases impact our vision? Lupus, very good. And diabetes, awesome. We all know diabetic retinopathy, like all of it affects, diabetes affects the eye, so does lupus. What medications may affect eye and vision? Again, that's a little bit more of a pharmacology question, so don't worry too much about it. But 2 drugs that really do affect vision are corticosteroids and diphenhydramine. Don't worry too much about that. I was really looking for the first part. All right. This question is talking about a patient who is diagnosed with SLE. They've been having chronic fatigue, joint and muscle pain, recurrent fevers without an obvious cause. We see a butterfly rash over the nose and cheeks. After complete exam, we diagnose the patient with SLE. Drug therapy with immunosuppressive and anti-inflammatory agents are prescribed by the rheumatologist. The nurse is planning an education session for the client about the disorder and treatment. So, is these actions indicated, contraindicated, non-essential? Remember, indicated is appropriate, necessary. Contraindicated means it could be harmful. Non-essential makes no difference. So, protecting yourself from sun exposure. Do we think that's good? That's bad? Or non-essential? Great job. It is indicated. What about keep skin lesions covered with sterile dressing? What do we think about that? Also remember, what is a lesion? A lesion is just, a birthmark can be a lesion. What do we know these patients are at risk for like skin issues that they might want to use? These patients are at really big risk for like dry skin and skin issues. So remember kind of that photosensitivity. We want to give them creams and lotions for their like skin lesions, that mild shampoo, that mild protein shampoo. So the lesions are actually contraindicated because we don't want to be covering up these lesions because it can promote really, really bad irritation to an already very dry, chalky area of the skin. So sterile dressings actually dry their lesions out a lot more. So that is contraindicated. But that one was a little bit difficult. What about report any infection to your rheumatology healthcare provider immediately? What do we think about that? Good job. It is indicated. What about bathe or shower no more frequently than once weekly? What do we think about that? So it is contraindicated. Bathing once a week. Remember, these patients, not only is bathing once a week associated with like lots of negative issues, but remember, these patients are at really big risk for infection. We want to prevent infection. If you're only showering once a week and you're kind of living your life with all of that yuck, bacteria, dirt, opportunistic infections all over the place. So that's actually contraindicated. Showering once a week for anyone could really cause harm, but especially patients that we need to keep clean and free of infection. What about performing at least 15 minutes of lower impact activities and strength building exercises daily? Yep, this is indicated. Remember, these patients are at risk for rheumatoid arthritis and some mobility issues, so really we want to have them do nice low impact activities to help build strength. Should we tell them to do not abruptly stop taking their medications? Absolutely, that is indicated. Does anyone know what the major complication of abruptly stopping steroids is? Pop it in the chat. Why do we not abruptly stop steroids? It has a little bit to do with tolerance. We need to taper. But what? Absolutely, Cushing's. Cushing's occurs when we abruptly stop taking steroids. So essentially, my body has built up a tolerance to steroids, so that if all of a sudden we abruptly stop and we take it away, my body goes into a freak out mode, my blood pressure goes up, I get that moon face, that truncal obesity, all of it. So yes, we never abruptly stop taking steroids. We must taper. Very good job. Should we encourage them to get the influenza vaccine every year? That's just the flu shot. Should these patients receive the flu shot? Is it safe for them to receive the flu shot? So it's actually safe for the patients to get the influenza vaccine. Why is it safe? the influenza vaccine isn't a live vaccine. Now, remember, if you're on immunosuppressants, you can't receive live vaccines. But the flu shot, it's not a live vaccine, so they're actually encouraged to get it because, again, they're on immunosuppressants. Their immune system is already a little bit lowered. So a small little flu could actually take a big toll on them. Should we have them eat a low-calorie diet with less animal protein and fat? What do we think about that? It is non-essential. It's unrelated. Very, very good job. Ideally, like, yeah, if weight loss is the goal, low calories, good. Less animal and protein fat, that's a healthier choice. Plant-based proteins are a little bit healthier, but is it pertinent at all to SLE? No. Should we have them rest more when fever is present? Awesome. That is totally indicated. We want them to rest more when they're having, we know fever is a sign of possible infection or exacerbation. So really rest is going to be the best. So very good job, guys. So the last thing we're going to talk about is smoking cessation. Okay. Here's some of the goals for the lesson and we'll move forward. So all forms of tobacco are associated with really bad health risks. So when we're encouraging someone to stop smoking, we really do want to review the benefits of smoking cessation, such as reduce incidence of CAD. We can prevent further damage to the lungs, reduce the risk for cancer, etc. When we're calculating pack years, all we do is multiply the pack per day by the number of years you've smoked. If I smoke 2 packs a day for 12 years, my total pack year is 24. So first step in determining are we ready to stop, we should choose a start date and get support. Really, how do we stay successful in recovery? We want to avoid triggers. Really get a list of why. Why do we want to smoke? Why do we want to quit smoking? Is there maybe a grandbaby on the way that we want to kind of have grow up in a nice, safe environment? Drinking plenty of water. Weight gain is expected, but we want to teach them to choose healthy snacks. They're going to want to be keeping their mouth occupied, so maybe some carrots instead of a whole bag of chips is probably a better alternative. And participate in activities that keep your hands busy. So, when we're talking about nicotine replacement therapy, I want you to keep one thing in mind. If someone is on nicotine replacement therapy and they smoke, they are at an increased risk for seizures. Okay, this is why it's really important that we do not have these patients smoking. It is really, really scary if they do. Okay. Couple different things we can use for NRT. Patches are the most common, especially in hospitals. They come in various different dosages. Lozenges, if your patient has a lozenge, it's similar to a cough drop where we want to suck on them. You don't just take it, swallow it, chew it. You just suck on it. Gum can be used. Teach them the proper way to do this, such as chew, 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 feel a tingle, park it in your cheek, wait for the tingle to stop, then chew again and repeat. This helps maximize effectiveness. Also teach them don't eat or drink anything before using it. It can kind of mess with the effectiveness. Inhalers aren't too common. They require a provider's order. Again, nasal sprays require a provider order. Your Chantix, your varenicline helps with the withdrawals and cravings. Just remember, it is contraindicated in cardiovascular disease. It must be taken with a full glass of water as well. Finally, bupropion, this is an antidepressant, but I want you guys to kind of remember that if they're taking bupropion, they can't really have any sort of psychiatric things happening, such as bipolar, head trauma, seizures, bulimia, alcoholism. I don't know the exact reason why, but that's just something I like to use to kind of remember the contraindications. Well, this is an antidepressant, think psych. When we're talking about contraindications, think brain, i.e., seizures, bipolar, head trauma, bulimia, or alcoholism. Okay. And that is everything I have for you guys. I know we started a little bit late, but I'm very thankful for all of you that came today.